have to concentrate, and you need to concentrate on complex carbohydrates that are rich in fiber. You do not have to restrict fruits and vegetables because these are kidney patients. But if you have a challenge of potassium, you may use the low potassium containing fruits and vegetables. Again, there would be a subset of diabetic kidney disease patients who will have sugars which are very good under control, or they are borderline lower. For them, sometimes we do recommend using less than 10% calories coming from even sometimes simple carbohydrates. So again, when you make your prescriptions for patients with chronic kidney disease having diabetes as one of the complications and which led to neuropathy, you do not restrict carbohydrates. Need to think about is the type of carbohydrate that we are going to be using, which is going to be complex, not simple. Again, most of us are dietitians here, and we know the benefit of this high fiber, high complex carbohydrate diet, because fiber acts as a barrier to the diffusion of essential nutrients from the gut lumen to the mucosa. Fiber-rich foods utilize the greater length of the intestine, thereby resulting in delayed absorption compared to the refined food. And that is why we need to give complex carbohydrate to our patients, not simple carbohydrate. Again, talking of fat, again, you have to give less than 30% of energy coming from fat. Okay, this counts for the visible as well as the invisible fat. So if I am talking of the visible component, I would be having around between 4 to 6 teaspoons of oil and ghee in my patient's diet, and my ratio for MUFA, PUFA and saturate would be similar to that what I would use in any cardiac patient. Okay, talk about the next important modification is on hypertension and fluid overload. Now, if you see National Kidney Foundation recommendation, it says a salt intake between 3 to almost 6 grams. They say no processed food, sodium should be restricted. But one thing that you need to understand when we are talking of our salt prescription, mind you, not sodium prescriptions, salt prescriptions, we may have to give a 0 salt to 5 grams of salt diet to our patients depending upon the degree of edema they have, the blood pressure that they maintain. So there is no particular guideline which will tell you that you have to use this much grams of salt, and the sodium restrictions you do need to implement in all patients who have diabetic kidney disease. Okay, now how do, when you are talking of salt restriction and sodium restriction, again these are good flavors which are adjuncts that we use in our kitchen. This is lime juice, vinegar, tamarind, kokum. Spices like spring onion, green chili, then mustard powder, cinnamon powder. We can use this in our food to make the food tasty with less amount of salt. Again, when you're talking of sodium, it is an individualized prescription, and salt substitutes, which are potassium based salt, with who have kidney problems. That's very important to understand. The reason why we are stressing so is because these are potassium based salts, and our patients may have a challenge of potassium. Hypokalemia is very common in people with diabetic kidney disease. So use the limited amount of salt that you can use for your patient, and use the flavors which you have naturally in your kitchen for your patients to make the food tasty. Another word of caution is on this low sodium salts. You know, when people start using these low sodium salts, if you read this, it says 15% less sodium than the iodized salt. People get into the notion that, oh, this is a low sodium salt, I can use as much as I want. That is not true. You cannot use the amount that you have. Even for this, the dietitians have to give the right prescription to the patients so that they don't overboardly use, and then the sodium contents of the diet increases. Because I don't know how many of you have tasted this. This has a lesser salty flavor, so the tendency is to use slightly more. So it's better whenever we are giving any salt prescriptions to our patients, whether it's for a low sodium or the regular salt, you write in grammage or in teaspoons to the patient what they are supposed to be using. Now, the most important modification that we need for these people to delay the progression of the disease is our protein intake. Okay, Now, different bodies have given the same recommendation. The protein intake between 0.6 to 0.8 is recommended. When you have a patient who's a non-vegetarian, you will stick to 0.6. When you have vegetarian patients, you can use 0.8 grams of protein per kilogram ideal body weight per day. That's the recommendation. Now, basically the therapy that we use in these people is low protein, which is supplemented very low protein, and I'll discuss both of this with you. But before we go to this, why we are talking of restricting proteins in diabetic nephropathy? So if you see this figure,
webinar.
Here you understand that in diabetes, the afferent arteriole, there is the expansion, or you see that there it gets dilated, okay, and the efferent arteriole, there is constriction, which increases the intraglomerular pressure. So when I reduce the protein content of these patients, by restricting the protein content, this dilatation of the afferent arteriole can be reduced and the constriction of the efferent arteriole can be reduced, whereby it will reduce the pressure, intraglomerular pressure, which will prevent or reduce the proteinuria and rate at which the GFR is getting declined. Basically, that's the reason, that's the pathogenesis because of which we are reducing low protein diets for this population. Now, is it true that everybody who has a diabetic kidney disease will benefit from a low protein or a supplemented very low protein diet? It is not so. Your choice, your selection of patient is very important. Why I say so is because that if I have a diabetic who has massive proteinuria, okay, when I say massive proteinuria in the range above more than 10 grams per day, and if I place him on a low protein diet, he may not benefit from a low protein diet because there is massive losses of protein from his body as it is. It is a progressive disease. The disease is progressing very fast, and again there is wasting. So I may cause malnutrition in this population. So subjects who have a slow progressive proteinuria, who have a slow progressive creatinine are the right candidates to use for this therapy. And of course, people who have no appetite or who have an active underlying other reason for kidney failure other than again diabetes or who have other organ involvements may not be the right candidate to place on these low protein or supplemented very low protein diets. So how do I determine that whom do I give what diet and how much restriction to be followed? Well, there is the nutritional screening and assessment that comes into play. You do a detailed nutritional screening and assessment for the patient. You evaluate what is the baseline calorie and protein intake of your patient, and to estimate the protein intake, because these are people where protein restriction is a must, you can use the 24 hours urinary urea nitrogen method, where as per this method, this was described in 1985 by Maroni et al., it was stated that for a stable patient, your nitrogen intake will be equal to your nitrogen loss. If I am able to calculate my nitrogen loss from the 24 hours urine sample, and from this sample I can do a 24 hours urinary urea nitrogen, I can calculate for extrarenal losses by using a formula of the factor of 0.031 into weight of the person in kgs, and I get the total nitrogen lost by the person in the day. 1 gram of nitrogen is equal to 6.25 grams of protein. If I know that the person is losing 6 grams of nitrogen, I multiply it by 6.25. I know that the person is eating about 37 to 38 grams of protein. So by using your traditional methods and using your urea nitrogen appearance method, you can calculate the protein intake of patients, and then you can decide that whether you really need to use a low protein or a supplemented very low protein, because these keto analogs what we use as a source of protein. There is some disturbance in the background. Hello? There is some background disturbance.
I have unmuted everybody, ma'am.
Okay. Okay. So when we are talking of using, you really need to make very close decisions with your patients. You need to assess them very well, and based on their appetite and nutritional status, you need to plan their diet therapies. Because what are the studies showing us? Well, the studies are showing us that benefit. They do show that you are able to achieve a slow decline in the GFR when you place people on these low protein diets. But in an attempt to retard the progression of the disease, please do not hamper the nutritional status of these patients, because eventually you do need to understand that they are going to progress towards end stage and they will need a renal replacement therapy. So if you see, as the kidney function declines as per the stage of chronic kidney disease, there is a drop in the BMI. Even if you see the MDRD trial, it clearly showed that people who had chronic kidney disease, even on an unrestricted diet over a period of time, as their disease progressed, they had dropped their intake. So the calorie and protein intake had dropped. So it is not necessary that many times when you see a patient with diabetic kidney disease, you have to restrict food. There may be patients whom you may have to add food, not restrict food. So just showing you a classic example of a gentleman whom I had seen, who had a history of diabetes and hypertension. Both were uncontrolled by him, and he was given a low protein diet somewhere. And when he came, he was following this diet for almost 2 years. And I just plotted his weight. He started with a weight of almost 88 kgs, and when he had reached me after 2 years of following this diet, his weight had come down to 75. So we do not want such a weight loss. Okay, and the person starts feeling weak after this. So as nutritionists, our aim is to maintain the nutritional status of our patient and then probably give them the right modifications so that you can delay the need of renal replacement therapy. But first thing that you need to understand is to maintain the nutritional status of the person. So what should be the approach? So this graph is just to show you that you need to do a thorough assessment of your patient. Your patient has a good appetite, has a good nutritional status. You can start using a low protein diet. If the low protein diet does not work with your patient, then probably you can offer the supplemented very low protein diet. Now, there may be sometimes people who, even on both the therapies that you offer, still are rapidly progressing. Then probably what you need to do is you need to symptomatically give them the dietary modification, maintain good nutritional status so that they can reach for the whatever therapy that they want to go, whether it's for transplant or dialysis, in good nutritional status. That's very important for us. Okay. So this is just to show you a standard prescription, how you can do the calculations for your nutrients. When we are talking of calorie requirements, it's 30 to 35 kilocalorie. Protein intake is between 0.6 to 0.8. Potassium restriction, sodium restriction, fluid restriction will depend on the patient's requirement. There are no certain guidelines which say that you need to use 40 milliequivalents or 60 milliequivalents of potassium, or you need to give a mild restriction of sodium, or you need to give only this much of fluid. But yes, for phosphorus, we do concentrate on 800 to 1000 milligram of phosphorus per day. When we are talking of the supplemented very low protein diet, all the nutrients remain same except for proteins. There we used a protein intake of 0.6 to 0.8. Here we use a protein intake of 0.3 to 0.4. Now, this is one of the papers that we had given on practically how you can plan these diets. You can refer to this paper if you actually want to see the menu plans and the recipes that I just showed you, the prescription, how we've translated that prescription into menu plans for our patients, vegetarians as well as non-vegetarians. Now, one important, complication of chronic kidney disease is hyperkalemia. So, is it so that all patients who have a kidney problem will need modification? It is not so. So you need to check the biochemical profile of the person. If the potassium is exceeding more than 5.5 milliequivalents per liter, you do need to restrict the potassium content of the diet. Otherwise, you can allow them to take the normal potassium if your serum potassium levels are between the normal range of 4.5 to 5.2 milliequivalents per liter. Now again, if your potassium is high, leaching is one thing that you can tell your patients. You can offer them low potassium fruits, and you can teach them to use methods so that you can reduce the potassium content of the diet. So that is something that is very important for our population. But one thing that you really need to remember is that disturbances are variable. diet needs to be individualized. No two patients are the same, though they both may be diabetic kidney disease. And second important thing is regular monitoring is very important for compliance. If you want your patients to follow, give them individualized prescription close to their normal diets. Only then they will adhere with your dietary prescriptions. So this is just the pyramid. Of course, whatever I explained to you, the pyramid also explains the same thing. This was given by the National Kidney Foundation. And thank you for your patient listening. These are some of the publications that I have come out with to help my patients to follow their diets.